All right, so I'm Cori Poffenberger. It's nice to see all of you guys here. Today I'm going to talk to you guys about how to move from handicapped to accessible and how to become more inclusive in your care for emergency department patients with disabilities. So I want you to meet my daughter Eliza. She's 6 years old. She loves purple and pink, riding horses, and of course, unicorns. She's a kid like any other with the addition of what we like to call a few extras, one of which is her wheelchair, because she was born with spina bifida. I'm going to share with you a story. A few years ago, we were seeing one of our physicians, who's one of my favorites, actually. He's very kind and considerate. He interacts really well with her. And at the end of the visit, he said to me, "Thank you for taking care of her." And I started to cry. It took me a minute to realize why I was crying. And it wasn't because I was so moved by his comment, but rather because I was angry. It was so upsetting to me because he saw my daughter's life as a burden, and he couldn't imagine how hard it was to take care of someone with a disability. I know that he meant well and he was trying to offer support, but he lacked the insight in order to understand the experience of disability. In medicine, our attitudes are the result of our beliefs and our values, but also of our experiences. Disability is common. It affects 25% of the US population, or more than 1 billion people worldwide. And yet this is a neglected topic in medical education and training. We do not get enough experience on how to care for patients with disabilities. The consequence of that is that ableism, or discrimination in favor of able-bodied people, is not only the dominant cultural norm, but is also our dominant norm in medicine. But we can change that. We need to start by being vigilant and thinking about the impact that our ableism might have on our patients. Some consequences of ableism might include distorted communication or possibly misaligned priorities between the patient and the physician. A manifestation of ableism is the medical model of disability, which states that people are disabled by their impairments or differences, and that those impairments or differences should be fixed by medical intervention. It's the square peg in the round hole, trying to fix it to make it fit. In contrast, the social model of disability says that disability is caused by the way society is organized, rather than by a person's differences, and seeks to remove barriers that restrict inclusion. So rather than putting the square peg in the round hole, let's create a square hole and allow everyone to participate. So the first strategy I want you to take home with you today is to use inclusive language. The language that we use when we care for people with disabilities has significant impact and can show them that we value them. I'll start by talking about places of accommodation for people with disabilities. So would you refer to this parking place as handicapped or accessible? The word handicapped should not be used as a property of a person or a place, but rather as a verb. For example, the person with a disability is handicapped by the lack of accessible parking spaces. If you compare this picture with the prior one, which one of those two spaces is handicapping and which one creates access or allows a person with a disability to be more included in society? It's not just handicapped. Here's a photo of the trackboard in RED, and you can see that this person in triage has been identified as being wheelchair bound. But is that truly the most appropriate and useful way to describe this patient? Or might there be a better term? The term that I prefer to use is wheelchair user. Wheelchairs are tools of mobility and freedom. My daughter has never been bound to her wheelchair, although I have no doubt her brothers would try it if they thought they could get away with it. Her wheelchair allows her to be included in society and to chase her brothers around a park. Similarly, words like suffering, afflicted, and even the positive word inspirational are not inclusive because they place the person with a disability outside of the norm of the rest of society. We don't need to editorialize or dramatize the experience. The second strategy I want you to take home today is to practice disability humility. Now, what that means is to try to understand the experience of disability with the understanding that you'll never have complete knowledge, that you'll always have a gap there, and try to behave as you recognize that gap. So what does that look like in your practice? It means that you presume competence and you allow the patient with a disability to be fully participatory and involved in their own care. That you ask them rather than making assumptions about their needs and their abilities. And it also means that the patient is the expert on their experience. So you consider the patient's perspective and their years of lived experience with their condition. And then you use that experience to help you provide them with the best care. That might mean asking them what is the best way to perform their physical exam. You have medical expertise that is invaluable to your patients, but it doesn't give all of us the right to pass judgment on our patients' needs, abilities, or quality of life. So we are physicians, and we practice based on the best available evidence. And for some time now, that evidence has been incomplete and influenced by an ableist point of view. Sometimes new evidence comes from peer-reviewed literature, and sometimes it comes from 6-year-olds who love unicorns. Thank you.
Thank you so much for that. If the judges could give us some comments.
Thank you, Cori. That was a very powerful message. It definitely highlights the importance of choices of our words and how they have a significant impact. Thank you.
Thank you.